All right. So I wanted to do a quick video on um, basically trying to get people up to speed on partial agonism. Sorry if you hear my cat; she's annoying as hell. Um, before I start, I want to talk about Ki and how that can be kind of confusing. So Ki is how receptor affinity is measured. However, what Ki really means is it's the concentration required to um, uh, basically um, um, to occupy, that's the right word, occupy 50% of receptors. So, and from that you can glean that lower numbers actually mean higher affinity. So that's what gets complicated if you ever are looking at a list of Ki values. Um, Low Ki equals high affinity, and high Ki equals low affinity. But I mean, for most extensive purposes, you can just talk about affinity and not deal with this Ki thing. It's just sometimes in literature and in older PowerPoints and stuff, they are comparing things with Ki. Ki makes a lot of sense if you're doing like chemistry equations and stuff, but that's well beyond anything clinical. So we can just talk about affinity, but I just wanted to cover that so that you don't get confused, by some other resource or something. But for instance, if we're talking about the D2 receptor, you can list drugs by affinity. So we could say high affinity, so lower affinity. And so super duper high would be something like Abilify and Haldol. Middle would be probably like Risperdal. Low would be like quetiapine. And we could go online and give a thorough list. But just the idea is, um, I want I want everybody to understand that Abilify hugs the D2 receptor very strongly, more strongly than Risperdal, and so that's a separate um, um, phenomenon than whether something is a partial agonist or an antagonist. So when we talk about those terms, we're talking about the downstream effect from the receptor. So if we want to review receptors real quick, this is a standard sort of lock and key model where this would be the ligand. This would be the receptor. This whole thing is a receptor. Um, and this would be like the binding region. And then, this would be the non binding region. Um, and so basically, the idea is sort of a lock and key mechanism, as they put it. The ligand comes in as the key to this lock, and when they connect together, they create some kind of downstream effect. some sort. They do something to the cell. The part of the protein that is in the cell changes in some way that allows chemicals that exist randomly in the cytoplasm to link up and be enzymically changed and come out different, and therefore cause these, downstream effects from this mechanism. That's not the only type of receptor that exists, and so we do get sloppy with our language. There are also like ionic pore receptors, which sort of, they have like a cylinder in the middle that opens up when the ligand, um, you know, comes into the binding region. Um, but for the most part, people tend to prefer the simple lock and key mechanism, and you can, talk about the difference between like six membrane GPCs or versus ionic pores versus voltage gated channels versus the other types of receptors that exist separately. We can keep it sort of simple in our conversation. Just talk about ligand and receptor. And I'm probably sloppy with the way I use the word ligand. I consider both the endogenous substrate like dopamine or serotonin or whatever's hitting the receptor naturally to be the that technically is the ligand, and these other drugs I think are called other things, but I call them all the ligand just to keep it. They're different ligands for the same receptor, or however you want to put it. Um, so, um, so when we're talking about what a partial agonist is, we first have to know the most simple cases, the agonist versus antagonist. And so if we have activity, which is really just the bang for your buck, it's how much of this downstream effect we're getting. Whatever the downstream effect is going to be, either if it's a pore style transporter protein that's just letting ions through, it's really like how wide is it opening, how long is it staying open. That would be the activity. If it's a transmembrane protein that changes shape on the inside to help catalyze reactions in cytoplasm, which is most of the interesting ones. Then just uh, the amount of activity that it's going to be spurring inside the cytoplasm would be its activity. But if we have activity on the Y, basically we'd be saying that um, so an agonist would be, let's just say, this is what dopamine would do to, um, and that's also what a standard agonist. That's what dopamine would do to the D2. And we're just putting that arbitrarily so that we can have a reference point. So there are things called superagonists, which would have a higher level of activity. Maybe like up there, so maybe a superagonist. Then they don't come into play that much clinically. You almost never hear about them being used clinically, but uh, I think in biochemistry, it ends up being a little more useful. Um, I'm on call, so sorry about that. All right, so yeah, so there are superagonists that exist, but they're not. They're I don't know of any really clinically relevant ones. And then of course we're gonna have partial agonists. I don't know why I did a second here. And then antagonists would be basically as close to zero as we could on this graph. Now, technically, there is often basal state activity, so there is usually some um, activity of the receptor even when there's no ligand binding. So that's why it is also possible to have what's called an inverse agonist, which actually stops that innate activity. But again, those aren't that clinically relevant, and so we can usually simplify the conversation by focusing on agonists, which sometimes we call full agonists to um, separate it from partial agonists, and antagonists. Those tend to be the most clinically relevant. Um, so, um, one thing that is true of clinically important um, partial agonists tend to have sorry, tend to have um, high affinity um, in comparison to other ligands. Now, I've never been able to get a true answer of is it something about being partial agonists that makes them have higher affinity? Like, do those two things have to exist together? Or is it just that the clinically relevant partial agonists that I've learned so much about all happen to have a high affinity because that's part of what makes them helpful? Um, if you want extra credit, you could try and dive into that question. But um, they tend to have higher affinity in comparison to other ligands. So with that, fits well with up here, Abilify being right here at the top, super high affinity for the D2 receptor. But it is a partial agonist of the D2 receptor. So let's list out some clinically irrelevant partial agonists because they're very interesting, and there's lots of them, not just in psychiatry, but so Abilify, of course, that's probably the most important one for you guys to really learn about. And inside the Abilify family, there's also newer drugs called like Rexulti and Vraylar. These guys make up the quinolone class of antipsychotics, and they're defined by their partial agonism at the D2. So these are D2. Another partial agonist that is clinically relevant that we do use and you should know about is Suboxone, or specifically the buprenorphine in the Suboxone. The other element of Suboxone is an opioid blocker, but this is the mu opioid, Suboxone, and let's see, what are some other? Chantix is a partial agonist at the nicotinic receptor. There are some others. I may come to remember them. This is really just trivia. It's not going to help you much. In fact, it just confuses me when I try to think about the relevance of it. But the metabolite of clozaril, norclozaril, is a D3 partial agonist. Take that for what you will. But also, you never want to leave out 5-HT2A, buspirone, good old buspar, partial agonist. All right. So partial agonists they come in all shapes and sizes, different receptor systems, doing completely different stuff. But you can see a pattern, especially with these top three that are actually, clinically relevant, these two are just sort of trivia, in that they have a higher affinity than the other ligands that are in our pharmacopoeia, which makes them especially helpful in some ways. So, whereas, let's say, risperidone would be a full agonist, um, and aripiprazole, or so Risperdal or Abilify, would be a partial agonist. So while aripiprazole will create less of a dramatic positive effect on the receptor, even less so than endogenous dopamine, which makes it feel like it's kind of an antagonist in a way, because if you were just flooding with your natural dopamine, you would get a higher response than you'd get if you were flooding with dopamine and then had a bunch of Abilify put in there. But the risperidone creates a bigger effect at each receptor. The Abilify hugs the receptor harder. And when you hug the receptor harder, you can knock off the other drugs. You can basically overcompete them. So that becomes especially relevant in a specific case. And this is one of the more important things for you to learn from this section here is that, well, let's go over a couple facts we know. This may seem unrelated at first, but it'll get there. So Risperdal causes increase in prolactin. It's one of the methods of causing side effects. And so that's called hyperprolactinemia. It's something that in the outpatient world, I do try and stay on top of it with at least yearly or every other year labs for my chronic Risperdal patients, especially males who can succumb to gynecomastia. Females, especially older females, might not notice much from hyperprolactinemia. But it is something that I do check outpatient, and I'm sure there could be a reason to check it inpatient sometimes. But so Risperdal causes hyperlactinemia. How does it do that? Well, it does that in the tubero-infundibular pathway. So if we call this the pituitary, and then this is, and sorry, it's such a gross-looking picture, but if that's the pituitary and that's the hypothalamus, there one of the dopaminergic pathways is right here, the tubero infundibular pathway. And I don't know why the pituitary is called the tuber. I guess somebody thought it looked like a potato. And infundibular, I forget the reason why the hypothalamus is called the fundibulum or whatever, but that's how you get the name tuberoinfundibular. It goes from the pituitary to the hypothalamus. And this leads to all sorts of sex hormone productions. You could review those, at your leisure. But the way that and the overproduction of that, eventually through stimulating hormones and this and that, and a whole song and dance that I could take a multiple choice test on, but could not necessarily lecture on at the moment. You get prolactin eventually, not from the hypothalamus. I believe it's from glands elsewhere, but you get prolactin. And I could be wrong. You could double check on that. It might be from the hypothalamus, but the important thing here is that the thing the thing that stops this, that regulates this and slows it down, is dopamine. So dopamine, is sort of an inhibitory chemical, the stop sign, if you will, to the production of different middle hormones that eventually lead to prolactin. Um, and so if you take away the stop sign, then you end up making more of the prolactin. And so risperidone is, remember, a full agonist, or sorry, a full. If I'd been just, I'm really trying not to confuse you guys, but confusing myself. All right, how have I been doing that like that? Risperidone is an antagonist. Oh my god. So risperidone is an antagonist. Jeez, I need my coffee or something. And full antagonist. And therefore, whenever it hits these receptors, it completely turns it off. And so it's really basically unleashing the prolactin growth. But a partial agonist gives enough of the dopamine activity gives just enough that it can usually shut down the overproduction. The fact is, this is a very sensitive circuit. It doesn't take much dopaminergic activity to regulate, but if you really shut off the dopamine activity, then it goes unregulated and you have this prolactin overproduction. So usually, Abilify can actually pull risperidone off of this system and actually fix the prolactinemia or the hyperprolactinemia caused by risperidone. So, therefore, a treatment for risperidone induced hyperprolactinemia is concomitant. My spelling could be off here. I suck at that. Prescription of Abilify. And the beautiful thing is, because of the receptor affinity being so much stronger with Abilify, you only need a low dose for the effect. So, because we want to be careful with antipsychotic polypharmacy, we want to have a reason for it. And usually just like 2 milligrams, even twice a week, doesn't even have to be every day, is usually enough to get the hyperprolactinemia down at least close to normal range. I usually don't worry as long as I'm within about 50% of the upper bound of normal. So I think the upper bound of normal is something like 25 or 30. And so if people are at like 38 or 42, I'm usually not that worried. If people are at like 75 or 100, that's where I'm worried that symptoms like gynecomastia, so that's men growing breasts, or amenorrhea. So that's women all of a sudden not having a period Also, galactorrhea. That's women spontaneously having liquid discharge from their mammary glands in their breasts. Um, all of those can start to happen when the prolactin level is left unchecked and gets more than double the upper bound of normal. Especially when it's at triple or quadruple is when it's much more likely. Um, so the old school, before we had Abilify, they, usually you'd end up having to brush up on your endocrinology or refer out for help because you're talking about like well, I don't know, like bromocriptine and like GnRH inhibitors and a bunch of meds that we're not experts in necessarily. So it's nice that a psych med actually fixes the problem of another psych med in such a beautiful way. Um, Now, another way to look at partial agonists, um, I try to explain it as several ways so that eventually you can see how I'm explaining the same phenomenon using different language and so you can really understand the phenomenon. One way that it gets explained is the light switch um, allegory or whatever. So this would be that a full agonist would be the light switch being on. The uh, the partial agonist would be like a dimmer switch in between, and the antagonist would be the light switch being turned off. Um, However, I've thought about it differently, and not so much with the switch, but with how bright a room is. Because if you're thinking about this light analogy, it's easier to think about a room with lots of lights in it because our brains have lots of receptors in it. We're not talking about one receptor, right? The light switch analogy really goes to one receptor. So if we're talking about like lights in a room, um, and each one has their own switch, so to speak, and sometimes dopamine is hitting a light, and so that's all the way on, and sometimes Abilify is hitting a light, and so that's halfway in between. Um, uh, or in a situation with risperidone, there could also be risperidone or something like that hitting the light, and then that light's all the way off. But we're in a room with lots of different lights. So when we're in the context of a relatively dark room, this would be a room where there's not much dopaminergic activity. There's going to be at least a little bit. There's dopamine in people's brains, but a relatively dark room, kind of dopamine poor environment. Adding in a lot of Abilify would add in a lot of halfway lit lights, which would brighten the room. And so a brighter room is technically sort of creating a dopaminergic effect, a pro dopamine effect. And I, until the density of the Abilify becomes so great that it's actually knocking off the endogenous dopamine, it will have a positive dopaminergic effect. When it's at a low enough density that the dopamine in your brain is able to hit as many receptors as it wants to, and then the Abilify comes in and hits extra ones, that actually is pro dopamine, and you can get that at low doses of Abilify. So if you look at like Abilify, just Abilify's receptor, so like D2 activity, you would say it actually goes kind of like this and then levels off. Um, and and if we were going to put risperidol in the same graph, risperidol would be like um, this, where it just kind of goes off to infinity. Or probably not to infinity, probably to whatever point is 100% saturated, but whatever. So the more risperidol you put in, the less activity you get, whereas Abilify is a little more complicated. This 2 milligram dose, for many people, is actually pro-dopaminergic. You can see signs of increased dopamine activity in a lot of people when you give them just 2 milligrams of Abilify. That's one reason why I actually give it to a lot of people with severe depression, along with their antidepressant, at this very low dose, because I actually want them to be waking up and having energy to do things, and the drive to do things, and the motivation, and all those good dopamine increased effects. And then it's only around 5 to 10 that you start to go um, toward the anti-dopamine aspect of Abilify, and then around 30 is where you're going to hit the max. Now, when you're looking at sometimes it's easier to talk about agonists, and the drugs, of course, as we just learned with my risperidol mistake, don't really help show this, because the drugs will all be in that direction with the antagonist. But a regular agonist, like just pure dopamine or whatever, goes like that, and the partial agonist tends to go like that. What I'm trying to show here is that partial agonists always have a sort of asymptote, where above this, so you get diminishing rewards from increasing the met. There's almost no change in the amount of bang for your buck between, well, let's call this might be like 20 of Abilify, and this would be 30. And for most people, not a huge difference in what it's actually doing to you between 20 and 30. And you get your biggest difference down there. And that's the way that all partial agonists are. That's why, like, Suboxone is a preferred agent over. Well, there's a couple reasons why Suboxone is preferred. So, why Suboxone over methadone? So methadone is a mu agonist, and Suboxone is a mu partial agonist. And when I say Suboxone, what I really mean is the buprenorphine and Suboxone. But I hope you guys get that. Because Suboxone also has naloxone in it, which is a blocker. So the when we're talking about people dying from overdose, let's say this is decreased pain, and up here this is death, and we don't want to get up there, right? And with Suboxone, it just so happens that really you get this asymptote really right before the pain is decreased, at least in most people. It's not ideal for pain. It requires pretty high doses for pain, but you get an asymptote effect, kind of like that. And for a full agonist like methadone, it's so and addicts, they won't read textbooks and learn that, like, Suboxone doesn't, like, amplify with extra dosing. And there is a street value to Suboxone, and people end up getting it without a doctor handing it to them. So I'm sure that many an addict has tried to get around here, this is probably what the addicts would call like the fun zone, um, with Suboxone, and just gotten frustrated with like upping it and upping it and upping it, because it has this asymptote, and you just get diminishing returns with more and more of it. Oh boy. Um, okay, so basically, I just want to end with just a quick review that Risperdal um, uh, has more um, antagonism to the D2 than Abilify per molecule. But Abilify has higher affinity. And I'm hoping that it's becoming obvious why you give out little bits of like microdoses of Abilify to sort of break the Risperdal blockade within the tuberoinfundibular pathway. Um, I feel like it's an especially beautiful thing. There's not a lot that our medications do that we can really tie to the science. And sometimes it feels like such an art of just like, taking out these wildly named things and, having people consume them and watching their behaviors change. But you can really, watch this on the labs, if they've been taking risperidol or risperidol like long actings, including the Invegas, and they have hyperprolactinemia. Um, you can fix it with just, microdosing of Abilify, and understanding why that happens and everything is beautiful. And it also demonstrates um, enough knowledge of the mechanisms of how this works that you know you'd probably be able to answer patients' questions when they do want to know why the heck you're choosing this medication, or how does this medication work, or something like that. Um, uh, you never want to not have an answer for questions like that. But anyways, I hope this has been informative. I want you guys to know that I really appreciate everything you do. Nurse practitioners make the hospital run, and you're also just awesome people. And go team.